All right, we have a great group here and our panelists on board. I'll go ahead and introduce our speaker today, Dr. Josh Kronenfeld. Uh, Josh is one of our outstanding general surgery residents who is working to complete his chief year. I've had the pleasure of working very closely with Josh the past couple of years throughout my fellowship, and I can attest to his outstanding work ethic and his wonderful fund of knowledge. We're absolutely thrilled that he'll be joining the group and being the next year's batch of surgical critical care trauma fellows at Ryder. And I'm sure we'll be seeing a lot more from him. I hope so at our conference with some more outstanding, challenging cases. So absolutely thrilled. Thanks, Josh, for putting this together. I know this is going to be a challenging but very, very educational case for all of us to discuss. So please, Josh, take it away. Good luck.
All right, so thanks so much, Dr. Cortez, for the introduction. I'll go through the case. I have a couple, transition slides, to kind of pause and discuss, but I'm happy if you guys want to interject or pause us at any time to discuss parts of the case. So thanks everyone for having me. I'm presenting motorcycle versus mesenteric of a superior mesenteric artery injury, and I have no disclosures. So I'll start with a case overview. The learning points from this case is we're going to recognize life-threatening hemorrhage and the need for prompt intervention. We're going to identify options for mesenteric injuries at initial operation. And we're going to understand the postoperative management of short bowel syndrome after trauma. A brief overview of the case. The data presentation was December 21st of this past year. The interventions that were performed were multiple exploratory laparotomies and then a subsequent IR drainage. And the primary injury that we'll discuss was an avulsion of the superior mesenteric artery close to its origin, likely after its after the first branch, after the middle collar. So the patient's a 31-year-old male with an unknown past medical history who initially presented to our trauma center after a motor vehicle or a motorcycle collision, rather. When he arrived, we started with our primary survey. His airway was intact. He was speaking in full sentences. For breathing, he had bilateral equal breath sounds. And for circulation, he was tachycardic to 122 with initial blood pressure of 95/50. For disability, he was initially a GCS of 15 with equal pupils that were reactive bilaterally. On our survey, he had abrasions to the chest, abdomen, and extremities. We did not note any other additional injuries on our inspection after exposure. The FAST exam, which I placed one of the images from the right upper quadrant here. You can see the strip of fluid in Morson's pouch between the liver and the kidney was indeed positive. So given his hemodynamic instability and our positive FAST, he was taken for exploratory laparotomy. So upon entering the abdomen at the laparotomy, we found approximately 2 liters of hemoperitoneum. There was an obvious liver laceration that we quickly packed. And we saw significant bleeding. It looked like it was arterial and venous in origin that was bleeding from the base of the mesentery. We couldn't tell exactly what this was, but he was hemodynamically unstable, bleeding a significant amount. So we quickly ligated these vessels. And then the other injury that we noted was a small bowel mesenteric bucket handle injury after about 45 centimeters distal to ligament of Treitz. So we performed a quick resection here. So I wanted to pause here. What are your thoughts on these injuries? And how should we proceed after this?
Thanks, Josh. I'll turn it over to our panelists to talk about how we would approach these injuries. First up, Dr. Kasim, any comments? We'll go to you, Dr. Hodgman. Any comments at this point?
No, not really, as you control the bleeding and probably do a damage control surgery and get out at this time, if you can control the bleeding. We know that there is an injury to the superior mesenteric artery, so I imagine that that's not an option, but so far there is no mention of ischemia of the rest of the small bowel, so based on the information I have, this is what it probably will do, but I have the feeling that there is something more here.
Dr. Kasim?
Well, they say that injuries come in three, and you have identified a liver injury and a mesenteric injury. You need to look for the third. at least you should try to look for a third. So having said that, there's significant amount of blood in the abdomen leaders, and it cannot be explained just from tear in the mesentery, but other vital organs. And of course, you need to look at the status of the bowel to see if there is any signs of ischemic changes. There may not be initially, and at least you should palpate the vessels, see if they are viable, and if there's pulsation present. And what you're looking for is to see if there is any underlying other vascular injury that you don't want to miss. And of course, when you see a buccal-and-buccal tear in the mesentery of this sort, you remove that segment of the bowel, staple it, and patient is hypotensive, and try not to do an anastomosis at this time, and save it for some other day or some other time. And I would be concerned that I'm missing something here. And I would try very hard to look for the third injury, and I'll stop there. Thank you.
Thank you, Dr.
Alright, yeah, Fiona. What? We're
Dr. Carter, any comments?
Yeah, I work at Ryder, and I'm counting my lucky stars that I don't think I ever interacted with this patient, but it's a substantial challenge, off the bat. I was getting multiple phone calls at the last slide, so it's possible I missed a detail or two right before the decision break, but I have to agree with the rest of the panelists. I mean, it comes back to the fundamentals of accomplishing hemostasis in the setting of hemorrhagic shock, and then reassessing for ischemia and what other interventions are required. That's all I can say.
Thanks, Dr. Carter. Dr. O'Connell?
I'll just echo what everybody else said, is the priority is number one, control of hemorrhage, and number two, contamination. Thank you.
All right, Josh, go ahead and continue.
All right, so as some of you guys alluded to, we did assess the bowel, given the likely injury was the superior mesenteric artery that had been ligated. The distal bowel, distal to that 45, we had 45 centimeters distal to the ligament of Trice that looked okay, where we performed the resection at the bucket handle site, and the rest of the bowel did appear dusky all the way up until the transverse colon. The proximal superior mesenteric artery and vein had been ligated, as we alluded to. And so, we knew we were going to have to either really resect most of the bowel because it looked like it was poorly perfused, or attempt a vascular repair at this time. I would note that he is, at this point, been well resuscitated. His base deficit was coming down. His blood pressure had come up. He was slightly tachycardic, maybe like the 105 to 110, but the blood pressure was in the low 100. So we thought that we could spend some additional time in the operating room to try and repair these vessels. Initially, we did consult our transplant surgery colleagues to assist with the repair. But while we were waiting for them, we did perform an arterial shunt between the superior mesenteric artery and vein. I'll show that in the next picture. But this is just a Netter diagram. We believe, based on the vascular distribution and further exposure of the vessel, that the injury was just distal to the first branch off of the superior mesenteric artery. So we think it was right after the middle colic artery came off that this was where the injury took place. And so here's our shunt that we performed. So you can see at the base of the mesentery over here, this is where we had our proximal anastomosis with the Argyle shunt, and we did shunt it to the vessel that had been ligated on the actual valve. The valve did initially pink up a little bit. Obviously, this was only an arterial shunt. We did not have the venous side being the venous outflow reconstructed. And at this time, our transplant surgery colleagues were able to get to the operating room to assist us. So what we did is we dissected out more proximally and distal the artery and vein. We removed the silk sutures that we'd placed to ligate these vessels. and performed an end-to-end anastomosis with Prolene suture of both the arterial and the venous sides. We did have Doppler signals in the bowel, and the bowel did appear viable with good perfusion, and there was some peristalsis towards the end of the case. And then we performed a temporary abdominal closure with planned second look. And I'll show some videos here. This was the venous anastomosis that we did first. Come into focus in about a second. But you see the two cut ends of the vein that we were able to bring together and perform an end-to-end anastomosis. You can see the many branches that we're showing coming off of the vein, or at least emptying into the vein. And so after the vein had been successfully reconstructed, we went ahead and performed the arterial anastomosis. And so on the left-hand side, you can see the vein that's now back together. And on the right, the patient's right side, we're performing the arterial anastomosis. It looks like they were coming together, relatively easily without tension. Like I said, we did mobilize them to get a little bit more length. And we're able to put them back together. Here's one last vessel after one last video after the reconstruction, so you can see the two vessels. Again, doesn't look like they're under much tension. Looks like the repairs are holding. So post-operatively, because the patient had a blunt mechanism, we were concerned. Obviously, we knew there were injuries to the abdomen, but we were concerned about additional injuries that we would have missed, including head, thoracic injuries, and fractures as well. So we did take the patient to CT scanner and found that there were bilateral small pneumothoraces. I'll show the images on the next slide. The liver laceration that we appreciated in the operating room, some rib fractures, as well as an L2 transverse process fracture. But of note, we did appreciate that there was an abrupt cutoff at the mid to distal superior mesenteric artery and vein, distal to the anastomosis that we had performed. There was also decreased enhancement of the mid-jejunum to the ascending colon. And so obviously we were concerned that our vascular repair had gone down at this point. I'll show the CT scan here. You can actually see the cutoff of the vessels. So no intracranial hemorrhage. There was some small apical pneumothorax, but really hard to appreciate. Nothing significant, nothing clinically significant in the chest. Some pulmonary contusions. But here the SMA is coming off. You see the abrupt cutoff. The vessel goes away. The temporary abdominal closure in place. Really no other significant injuries that we could appreciate on the initial CT scan. So I sort of paused here to think, what should our next steps be, given his status and then given, the new findings on the CT scan.
Thanks, Josh. It's obviously a devastating, very complex problem, very challenging problem. I see that our transplant colleagues have joined us as well. I'd love to get some commentary from them here in a second. I'd just like to start and ask if any of the panelists have seen this injury before or have anything to comment with regard to their own experience, management in terms of intraoperative decision-making and techniques, and then ask about embolectomies as well, if that was done, if that was confirmed. I can start with you, Dr. Kasim. I'll run through the panelists, and then I'd love to talk to our transplant colleagues as well who have joined. Thanks for joining. Dr. Hodgman, any comments at this point?
No, this is a very bad situation to be. I had experience with this, but penetrating. I don't think I have an avulsion that was a blunt injury. I had many of the handle buccal handle, but not at the root of the mesentery. A few problems that I think that I don't have a solution. I have questions. One is these vessels were ligated, so most likely there are clots inside those vessels, even if the anastomosis is successful. So as you asked before, was a Fogarty attempted to pass, or it was a viable option? Maybe it was not. And two is because of those vessels being ligated for a period of time, I will normally we will have given consideration to the use of heparin or during the case. However, this patient, you still do not know if he has a head injury or a spinal injury. You don't know anything. So it's a very gutsy move to administer a heparin bolus in a patient like this. Another option is to do local anticoagulation, and we have done that and diluted heparin injected directly into the vessels before applying the clamps. But this is unfortunately a very bad situation to be in, and I don't think too many people have experience in blunt avulsion of the superior mesenteric vessels. So that's all. More questions than answers. Thank you.
Thank you, Dr. Hodgman. Dr. Kasim, any comments?
Well, one other thing that I have utilized initially is instead of heparin initially, and try some papaverine as well, causes some vasodilatation, and follow up with plus or minus embolectomy if you deem necessary, and then go ahead and do the repair with the temporary shunt in place, just like you do an argyle shunt in the neck, and put a small stent in there because you're going to go back and look at it again. And what it does is it prevents any concomitant intraoperative thrombus formation at the area of something that I have seen used. I personally have not used, and it was a successful case in that particular instance. So those are the thoughts I have.
Thank you, Dr. Kasim. I think also one thing we haven't brought up is an on-table angiography after maybe the utility of that. Go on, Dr. Lenin, any experience with this injury and comments on management and what you would have done?
I mean, yeah, this is not a common injury, right? Blunt. I mean, I've had SMA injuries, but not complete transections of both the SMA and SMV at the same time. And is there any thought of like just keeping shunting him for a while? The problem is obviously the vein and letting him recover. But I guess what would the next step be is I guess you got to try to take him back at this point. And then you can decide interoperatively what you see. He's going to need that at least an attempt at revision, thrombectomy, potentially, TPA down that the distal artery. It's not a great situation because once it starts to clot off, it's going to keep trying to clot off.
Thanks, Dr. Lenin. Dr. O'Connell, any comments?
I did see one injury to the SMA in my career in Syria was a IED explosion, which took out the celiac and the SMA. But we were in a very austere situation, and by the time we had gotten control of the hemorrhage, The patient was basically moribund, and we had run out of blood products to resuscitate him. So unfortunately, we had to stop at that point. We had no way to really revascularize him. So you already have exceeded my capabilities or my experience. I would say, if this guy did have a very bad hospital course, or if he died, I wouldn't take it too personally. In my opinion, this is quite possibly a fatal injury from the outset. And then don't feel bad about your anastomosis going down. First of all, we don't really do anastomoses of this type, maybe ever in our careers. And second, if it was a blunt injury, you're going to have a much more challenging artery and or vein to work with. It's going to be traumatized. It's going to have a tension injury. It's going to perhaps have been dissected. So it's not going to be a clean cut as with a knife injury or a gunshot wound even maybe. So your chances of that anastomosis staying patent are probably going to be less than with a different mechanism. And then, if you're talking about doing an on-table angiography, I was thinking about that, but again, this is not how many people have done this in their careers or are good at even interpreting what that angiograph is going to look like. It's far beyond the experience of most people. So I would say that you guys have already done much better than probably a lot of other people on this panel, or you're just lucky, which is just as good. But very interesting case.
Thank you, Dr. O'Connell. Great comments from everybody. I'd like to pull the transplant group. I see Dr. Vanesh joined. Dr. Tekin, just about your experience with this case and any insight you can share.
Yeah, sure. This is Dr. Tekin, one of the transplant surgeons. Actually, I did this case with Dr. Vignesh, my colleague. So obviously, as everyone said, there are a lot of concerns to do this kind of repair or reconstruction. But the first thing, I think, let's start from the potential options. One, as they did already, they ligated the vessel to prevent the injury from bleeding. And second, you can take out this remnant bowel because it just happened. And with the shunt, temporary shunt, it looks like still dusky, but partially maybe viable or potentially viable. You can take it out, flush it like we do the intestinal transplants and auto-transplant it, which requires either orthotopic intestinal transplant, which means that you will connect the SMA to SMA and SMV to the portal vein or SMV. In this case, probably would not be possible. Plus, you will take the bowel out, already injury, and then you might have to use a graft and everything, which is potentially infected area. So that option, we didn't elect to do that. We are lucky here because we are one of the big intestinal transplant centers. So we have some experience with that. It was not first intestinal procedure for us in terms of transplant. We could do that, and we took that as an option. The other thing in the consideration, there was about 60 centimeter proximal small bowel, or maybe 50 to 60 centimeter from the ligamentum of Treitz, completely viable. Why? Because there was the first branch from the SMA still intact. So that gives us, okay, whatever happens, we have some bowel, either for potential rehab with elongation procedures, or even if we fail, we have some bowel to bring an ostomy, and then eventually this guy, young person, can go to isolated intestinal transplant. So these are all thoughts. And then we look at the injury, and we dissected a little bit on the first SMA to see if there's an area. This was not a clean cut as mentioned, it was an avulsion. So there was some intimal dissection there, and we tracked it, and it was still okay, just distal to that branch. So we said, okay, we can probably do this anastomosis. And the other thing, when you look at the shunt, it's a far distance, but this is a mobile small bowel. It comes very easy. The problem with that, it's mobile, yeah, it comes easy, you do the anastomosis, but when you finish the anastomosis, it can create a tension, especially in the vein when you do that, and then cause some, basically clot and everything. And in terms of clots and taking care of the blood vessels, we flushed it and we did some, Fogarty. There was not really much clot there. So it was a good flow from proximal, and the distal was as best as we could say at that moment. I'm talking about the artery now, looking good. Then the vein, the problem with the vein, we were a little bit concerned because it was ligated, obviously, to save the patient blindly just below the pancreas. But the vein injury for us in that area was easy to handle. Why? Because there was a flow coming from the splenic vein. When you open and declot that area that you are going to connect back was perfectly fine. So you can see that there's no clot there. It's like backflow. And then we look at the proximal side. I'm sorry, the distal side from the bowel. That was a little bit challenging. Why? Because it was very close to two distal separate branches of the SMV, basically going down. So you have to do this anastomosis right there without occluding any of those two vessels, because there was not much vein left there. Again, when you bring this up, it looked pretty good. It was not under tension. And the other thing we do, obviously, we flushed again with heparinized solution, and mentioned here that we couldn't give the full heparin without knowing the injuries in the head and everything. What we did is, after we opened the arterial, we didn't basically tie the venous anastomosis. So we flush a little bit the bowel after we opened the arterial thing. So if there's any clot that we can get rid of, maybe like that way, potentially, but it didn't look like anything. So, I mean, we looked everything we could do in terms of declotting if there's any clot there. And there was not much clot issue, I think. And then it looked excellent, viable bowel with both flow. And now I think we are going to go to the second part of the discussion after what happened and why it happened. We can comment maybe further after Josh talks about it, and we can discuss. If there's any specific question, I can answer also.
Thank you, Dr. Tekin. Wonderful comments. Josh, go ahead, continue.
Okay, yeah, thank you, everyone. So we did take the patient back. At this point, it was early in the morning on the the following day. The initial operation was around 11 p.m. midnight on the 21st. This was on early in the 22nd. So we performed a reopening of the recent laparotomy. We did revise the two anastomoses with thrombectomies, and then we did the arterial and the venous anastomoses. As you can see, the way the bowel looked on the photograph here, the cecum looks obviously concerning. So we performed an ileocecectomy and left the patient in discontinuity at this time. As some of you guys had mentioned, we could have considered a heparin drip initially, but without knowing the status of his other injuries, we deferred. But at this point, we had done a full scan and knew that he did not have any intracranial hemorrhage, so the decision was made to start him on a heparin drip at that time. And so he remained intubated, went back to the intensive care unit, and for the next 2 days, remained intubated. The bowel did appear pink through our temporary abdominal closure. Our lactate, which was initially 7.3 after the second operation, did trend down, but plateaued at about 3.5. He required some continued resuscitation, but for the most part, he was well resuscitated. Still requiring some vasopressors, though, which were trending down over time. He was nearly off vasopressors by the 24th, and the PTT at this whole time was within therapeutic range. And so for the third time, we took him back to the operating room. This is on Christmas Eve on the 24th. At this time, we had another 120 centimeters of necrotic small bowel that was resected. We did look for the arterial and venous signals within the just distal to the bypass, and then also within the arcades of the viable small bowel, and there were good signals. So we did not feel the need to revise the anastomoses. We just continued with the temporary abdominal closure, with again planned for another look. And so he still has 45 centimeters distal to the ligament of Treitz, and now he still has a significant amount of small bowel, but 120 centimeters less, as well as lost his terminal ileum and cecum. This is just a video of the take back on the 24th prior to our resection. You can see these patchy areas of necrosis of the bowel, but there is still a good amount of bowel that appears pink and viable. And you can't see it in this video, but was peristalsing. It look rather nice. And so over the next 3 to 4 days, the patient was extubated. The bowel appeared again still pink through the temporary abdominal closure. Our lactate was trending down. Our vasopressors were off. And the PTT was within therapeutic range. We're actually feeling pretty good at this point, given the constellation of his laboratory and clinical picture. However, when we took him back to the operating room on the 27th, there was another small amount of non-viable intestine, about 15 centimeters, that we resected. And again, the arterial and venous anastomoses appeared okay, and the remaining bowel looked relatively well perfused. At this time, the bowel had been in discontinuity for a long period of time, and so we wanted to decompress the bowel. So we performed an end-jejunostomy, 45 centimeters distal to the ligament of Treitz on the patient's left side of his abdomen, and then we performed an end-jejunostomy to decompress the remaining bowel that had been stapled off in a closed loop for some time now. We brought that out from the right side of the patient's abdomen. We did place some retention sutures at the time. I'll show you some pictures of the next image. Next slide. And you can see that there's a Jackson-Pratt drain that we placed here. There was a little bit of saponification that we noted the inferior border of the pancreas, likely where either the injury took place or where we were working. So we placed a Jackson-Pratt drain near the pancreas. You can see on the left-hand image, we placed some retention sutures with some white granula foam up against the bowel, but it's not directly against the bowel. There's still a piece of plastic, what we use for our temporary abdominal closures. And then you can see on the right-hand side after we placed our ostomy bags and finished the wound back. Again, the patient was extubated, was returned to the intensive care unit. His lactate trended up to 2.0, but he remained off vasopressors, and his PTT was in the therapeutic range. We did take him back, however, on the 29th. And at this point, this was concerning for us. We noted that the bowel, the proximal 45 centimeters of bowel was viable and still looked pink, and actually had some bilious output from the jejunostomy. However, the remaining bowel no longer looked viable. Actually looked pretty necrotic. There were still some signals within the proximal mesentery, but distally, we no longer had any flow through the vessels. So at this point in time, we did a definitive closure of the abdominal fascia. I think we were able to get him closed, partially because we removed the remainder of his bowel, and we did close the skin loosely with staples. So his bowel map, what he really has after this procedure, he has stomach duodenum, 45 centimeters after the ligament of Treitz to an end jejunostomy. And then he has basically distal ascending colon to transverse colon, and then the remaining remainder of his colon and rectum is all intact, but stapled off as a long Hartmann. So I can pause again now, for some additional comments about your thoughts about our management up to this point, and then what we should do, moving forward, given the patient's now short gut with only 45 centimeters of small bowel.
Thanks, Josh. Obviously, extremely difficult situation from the very beginning. I'll go ahead and start with Dr. Hodgman. Just any comments up to this point of the case, and then to address Josh's question here in this slide. Thank you.
No, no comments about the management. Unfortunately, this is what happened many times when you have this degree of ischemia, that you need to be very conservative in the resection. You're trying to save as much of the bowel as possible, and each time that you go back, you find more dead bowel or bowel that is very ischemic. One point about the lactate. In patients like this, the lactate eventually becomes unreliable for two reasons. One, the area of ischemia might be too small to increase the lactate effectively. And two is when the bowel is dead, doesn't make lactate anymore. So in these cases, if it's present, it's helpful, the elevated lactate. If it's not, doesn't help you too much. In terms of the management of this patient, it's needless to say, everybody who has a little bit of experience knows that this is extremely challenging. These patients very quickly start feeling better. They want to eat or drink, and the moment that they drink, I don't know, 500 cc's, they lose 1.5 liters. The electrolyte abnormalities happen very quickly. If they eat and they still have pancreas, they lose a lot of pancreatic enzymes, which leads to protein malnutrition because the pancreatic enzymes normally digest themselves and the amino acid get reabsorbed, except that this patient will lose all those pancreatic enzymes. So it's very, very difficult to manage, very challenging psychologically for the patient is very, very challenging. One thing that we normally do with these patients is we start the proton pump inhibitors because they have increased secretion of gastrin from the antrum and the increased gastric fluid that it will exacerbate the losses. You have to keep them MPO, unfortunately, for a long period of time and start any liquids very, very slowly. They need to be on TPN. He doesn't have, I think, enough bowel to become independent again. Usually, in a young patient, 2 feet of a small bowel with time, they can be independent of TPN or partially dependent getting TPN, cycling the TPN either at nights or every other week. But this patient doesn't have too much. We have been using a new medication called Gatex, which increased the size of the villi and increased absorption. And I have to say, when we started using it, I was very skeptical that this was going to work, but I have to admit, in 2 patients so far, okay, so in the Journal of Anecdotal Surgery, the results were really surprisingly good. Under ideal circumstances, you want to reconnect the bowel to whatever remains of the colon because makes the management of the fluids a little bit better. Still, the patient will have malabsorption, but managing the fluids becomes surprisingly much easier, despite the fears of massive diarrhea, becomes much easier. And try to make the patient better to eventually, particularly a young patient, to go for a small bowel transplant. I have a few patients that they did well while waiting for the small bowel transplant, but I always remember a young woman that she became so immunocompromised with no bowel that we never thought that she could get to a transplant because she was admitted every week with a new infection. Eventually, she got candida in the vitreous in the eye and need to have injections of amphotericin into the eye because of the severe immunocompromise until she got the transplant. But these are incredibly challenging patients and very frustrating for the patients to be in this situation. And in elderly patients, many times we do not offer anything else because they would not survive. We are going to make their quality of life so miserable that it's probably not worth continuing the treatment. But this patient is young, so you have to try to offer as much as you can. That's all I have. Thank you.
Thank you, Dr. Hosman. Wonderful comments. Dr. Kasim, any comments?
That was a wonderful presentation from Dr. Osman, and I don't have anything to add.
All right, thanks very much. Keep moving through here. Dr. Lanine, any comments up to this point?
I mean, you do what you can do, and you tried everything to save the bowel. Now, I think I agree that Gatex, we have difficulty getting it. You got to go through all the hoops to try to get it, but the surgical nutrition service here uses it frequently to help with absorption, and they've had good results, and they've been able to get people off TPN with a very short bowel. So I think it's an option.
Yeah, I do see while we have that discussion and this light up, Dr. Barta and Dr. Valenzuela, part of our surgical nutrition service, would love to hear any comments from you all or any insight.
Yeah, so definitely we had patients, like we do use Gatex, you just need to have approval in order to prescribe it, but we do treat patients with Gatex and we do see very good results with that. We have a whole rehab program, and that it's not only the Gatex, but the Gatex is the last tier of our management. Specifically this patient, 45 centimeter, he will need to have his bowel put back together eventually. We currently have him on TPN, he's at home on a brat diet for comfort. And essentially, I have patients that are almost off TPN with shorter bowel on Gatex. So definitely there is room for hope.
Wonderful, thank you. I'll turn it also for some closing comments on that up to this point of the post-op course from Dr. Tech and Dr. Ganesh, the transplant team.
So the second part obviously is a challenging question and problem. We question ourselves when we have complications. We call it a complication, even if you think that, okay, this was not even salvageable. But we looked at the end of the first operation, we didn't close, obviously. The bowel was swollen. We put a wound back. And we know that even if you put a wound back, maybe we think retrospectively, we should even leave it a little bit more open, not to put any pressure if there was some. There might be one contributing factor, this clot both in the vein and the artery. And the second, when we did the second repair, the thing was already a little bit more clear for us because the bowel was very ischemic, and then yeah, it pinked up. It's a vascular flow, and with no basically clots in it. We did the same maneuvers and Fogarty, this and that, but the bowel was not moving. And that's one sign that, you know, you have some really dead bowel. And since he was very young, and then the decision comes, okay, if you keep this bowel, which is perfused now with no clot, and he actually had good flow for the next 4 or 5 days, if you leave it there, will it cause any life-threatening issue? Yes, it can. Obviously, you can translocate, get septic from that and everything. But we are over there 24 hours with the trauma team. We work very close. We said, look, it's easy to take it out. And if something happens in terms of like, you know, potential sepsis or something, or infectious looking issues, any hemodynamic changes, we can just go and take it out. So, because we spend so much energy and time, and he's young. So as we discussed, whether we can save some of this bowel. But I knew that in the second operation, most likely this would not be possible. In the first one, I was very hopeful. So, you know, the first shot was the real shot. And we failed on that, unfortunately, whatever we did. So, I mean, you know, that's, as I said, retrospectively, when we look at it, we probably can do a little bit better. There was a little bit intima when I did the second time that I saw in the arterial anastomosis, because as you remember, I said it was an avulsion, not like straight cut. So we trimmed the proximal artery a little bit better and did better anastomosis, I would say. But I'm just a little bit more kind of on the edge, like maybe we should just leave it completely open with everything happening, like, you know, even if he leaks as much as he could from the abdomen, we could handle better. And in terms of follow-up, yes, as mentioned, I would connect them quickly from the to the colon, so you will probably get rid of some of the dehydration issues and electrolyte issues from using the remnant colon. Gatex, they definitely can be used, and we have an option to do his young intestinal transplant if everything fails. But he will have some good time if we can connect them quickly. Those are the comments I would add.
I got a
Thank
question.
you. Yes.
You got your CAT scan, so you know that he doesn't have a head injury, doesn't have a cord injury. Did you give any thought to, or did you give him any heparin after that CAT scan?
Yeah, he was on heparin after, as far as I remember.
Ah, okay. All right. I didn't see that, so.
Yeah. We even wanted to give him the first repair, but obviously this was a concern, and we couldn't. Because all those vascular issues, you have to give it. We do it normally in our transplant cases and everything. We put them after transplant on heparin drips. especially with the isolated intestine. It's much more, difficult to keep those vessels open in the small grafts. But in this case, we didn't give it at the first one. Yes.
I understand the reason. You needed to know what the rest of the body's doing.
Yeah.
At this point. So I just wondered. Thank you.
Thanks, everyone. Wonderful comments. Back to you, Josh.
Thank you, everyone. So I think we're running a little bit low on time, but I'll just go through some of his post-operative, course. So over the next 2 weeks or so, to January 16th, he was initiated on TPN. As mentioned, our surgical nutrition team, which are an amazing team of not only trauma and critical care surgeons, but also those that have an interest in intestinal rehabilitation and surgical nutrition, were on the case and assisting with the management, or took over the management rather, for this patient. His initial jejunostomy output was over 3 liters. At one point during the course, he was started on a brat diet with loperamide to decrease his jejunostomy output. And a subsequent CT scan was performed on the 16th. I'll show that in a second. I did show multiple intra-abdominal fluid collections. The Jackson Pratt drains that we had in place were not adequately draining the collections, as well as a small abdominal wall hematoma. You can see some of these collections that the radiologist has marked near the pancreas, and also on the right cardiac gutter. And a small abdominal wall hematoma. So these collections were drained by the interventional radiology team here. Eventually, he was switched back to NPO due to persistently high jejunostomy tube output, with TPN to replace the fluid losses, as well as provide parenteral nutrition for him. He was discharged home on the 22nd of January with outpatient TPN, but did present to the ER again about a week to 10 days later with fevers and emesis at home. I'll show the CT scan next, but it did show decreased size of the abdominal collections, as well as the abdominal wall hematoma. And so you see the pleural effusion on the right. The etiology really of his emesis and fevers was, the emesis was really not known at this point. The fevers was attributed to the central venous line that he had in place. And so this was removed upon his readmission to the hospital. He did eventually grow MRSA from the central line, which, as I mentioned, was removed with parenteral antibiotics that were initiated. He was started on peripheral nutrition as well as peripheral hydration, and continued NPO due to his abdominal distension and emesis. Nasogastric tube was placed, and then eventually a CT scan with oral contrast was ordered. I'll show that on the next slide. You'll see some more significant pleural effusions on the next image. But of note that the oral contrast does reach through the entire small bowel, and it does exit through the jejunostomy. So there was no functional obstruction at this time. And you can see some of the collections are better. Drain still in place. You see contrast near the ostomy site. So over the next week or so, he was eventually restarted on his brat diet with increasing doses of loperamide to decrease his jejunostomy tube output. He was transferred back to TPN with a new PICC line placed, and then it was discharged home with outpatient follow-up. As Dr. Barta mentioned, he's still being managed as an outpatient with hopes of getting him off TPN in the future. But we'll see how he does. I mean, he is young. That's very fortunate for him, and hopefully he will do well. I have a couple brief other things. I don't know if we want to pause here, Dr. Cortez, or
Josh,
okay. It really, there's not a whole lot of literature, and some of these articles are actually very old. Really just to point out that these things are exceedingly rare and exceedingly fatal, especially trauma to the proximal superior mesenteric artery. This is an article from 1992. Again, case reports. Here's another one from 2007. This is a success. But really, I looked through a considerable amount of literature looking at PubMed, and there's very, very few instances of blunt injury to the proximal mesenteric vessels that result in in salvage of all the bowel, let alone a favorable outcome. So I think we were happy at least to get him through the hospital stay, get him to discharge. Obviously, we wish that we could have saved more of his bowel, but we're hopeful that our surgical nutrition and intestinal rehabilitation colleagues are able to rehab him and get him through some of this. I'll put some final learning points. That blunt abdominal trauma can result in these significant injuries to the mesenteric vasculature. Obviously attempts, if possible, if the patient's not stable or continues to bleed, you may need to do a damage control at this point. But if you have the opportunity to, you should try to repair these mesenteric injuries and mesenteric vasculature. Obviously, adequate nutrition and fluid intake must be maintained in these patients with short gut that have high outputs, severe electrolyte derangements, and then obviously severe malnutrition. And these patients require close outpatient follow-up, to treat their complex management at this time. Just want to put up, these are amazing. These are all the faculty, that really helped to work closely with this patient. Top line were the surgeons that operated, the trauma surgeons that performed operations on this patient. Second line are the amazing, so top line, Dr. Nemayas, Dr. Kaufman, Dr. Mezoso, Dr. Sleeman. Second line, Dr. Valenzuela, Dr. Barrio, Dr. Hart, and Dr. Byers, who are our trauma surgeons as well, but our intestinal rehabilitation and surgical nutrition colleagues. And then Dr. Tekin at the bottom and Dr. Vignesh, two of our amazing transplant colleagues. So just want to thank them all for their support and taking care of this complex patient. And thank you, and I'm happy to take any additional questions or comments at this time.
Josh, wonderful job. Yeah, you really see this, frequently we say it takes a village to take care of these complex problems. And I think in this case, it really did take a wide collection of experts from many different fields. As we close out the hour, I'll get some closing comments from our panelists. Dr. Hodgman, any comments?
No, really, very well managed. Congratulations. I don't have anything to add. I see that Dr. Untrach is also here, and Dr. Oh, he's not here anymore. So, okay, so it's only Dr. Untrach. Dr. Frisbee was here too. Maybe they have.
I'm still here.
Oh, okay. So maybe they have something to we miss or something that they would like to ask.
Any comments, Dr.?
Well, I missed the first part of the presentation. I was a little late, but it just sounds like handled beautifully. All the expertise, and I don't think anyone could have done better. Anyone else could have done better with this case.
Thank you, sir. Dr. Lenine, any final closing comments?
No, I mean, I don't think anything else could have been done.
Dr. O'Connell?
I'll agree with the other panelists that it sounds like this guy's life was saved by all the interventions, and they were done properly. I think the morbidity comes from the patient factors, which you guys can't control. But I do feel, I don't know if this has been expressed by the presenter, but this is going to feel very unsatisfying because you may have a patient who is alive who wishes that they were not. This is a patient who is going to be probably on TPN, it sounds like, forever. They're going to have, they haven't even been, a month or so out, and they're already getting recurrent line infections. You can count on that happening for as long as it is that they live. They might get a small bowel transplant, but in some opinions, that can be a cure that's worse than the disease. Those patients often have a very rough course. It's despite everybody doing their best work and doing everything right, it can lead to a very unsatisfying result. And I don't fault anybody for that, but I don't know what you want to call it. You want to call it, being a grown up or being a doctor and having to deal with these issues. But I would say this patient is in for a very rough course, but not through the faults of the presenters and the doctors.
Yes, sir. Absolutely fair points. Dr. Tekin, Dr. Vinesh, any closing comments?
Yeah, I just want to thank Josh. Did an excellent job. And here, obviously, Miami, we have the advantage working with the trauma team as a transplant team, nutritional surgical team together for many years. So, in my opinion, this patient is safe for now and for future. Why? Because intestinal transplant has a lot of downfalls, but our results are pretty satisfying for isolated intestine. Now, 1 year survival almost 80 to 90%, and 5-year survival is about 60% with the intestinal transplant as a last option. This guy still has an option to live with the partial TPN as long as you follow the veins, like prevent recurrent infections, and we have a team for that, and using some new medications like Gadex. So he has a good chance to even have a quality of life, not downgrading the real problems come with the transplant immunosuppression. But this is one of the centers that we can hopefully provide this if it comes to that. As I said, that's always the last option. That's the reason we try so hard. So for me and for us, it was easy. Okay, let's ligate it, take it out. When he needs a transplant, we will do it. No, we don't want to do that because we know what it comes with the transplant too, because we have been doing this for a long time. And as a second, there's a question here: can we use as a splenic artery as a graft? Yes and no, because it's not that easy. I mean, we use splenic artery for hepatic artery reconstruction, or sometimes in the bad liver transplant cases. To clear that is not that easy when there's a damaged abdomen, and the piece that you can get might be a short. But yes, you can use the proximal splenic artery because spleen will still get blood from the short gastrics there. And we ligate the splenic artery for different reasons, and people have still normal spleen and survive the splenic artery ligation. Yeah, short answer, yeah, you can use it, but the question is whether it's going to be enough when you needed a long graft or not. That's a different question. I think more you have to mobilize the graft intestine and bring it up and connect it without any graft if you can. And when you do that, you have to know that if it stretches, it will clot too. So it's like always, there's a catch with whatever you do, but we try our best.
I would like to take this opportunity to congratulate Josh for taking care of this patient from the moment he came in to the moment he got discharged.
Thank you all for your wonderful teaching. Dr. Tech and Dr. Vinesh, absolute pleasure to have you all join us, and all of our panelists. Thank you. Congratulations again, Josh. Wonderful case. Hope to see you at a lot more of these. I'm sure we will. Dr. Martos, are you there? The closing comments? I know he was saying he was scrubbed, so I'll go ahead and wrap that up for the group today. Thanks everyone for joining again. Congratulations, Josh, and thank you to all of our panelists. We'll see you for the next one.
Thank you, Josh.
Thank you, everyone.